This video is going to show you how to make a dichotomous key for infectious agents associated with a particular clinical sign. And my hopes with this is it'll really help you organize all of the different infectious agents, not only that we've talked about in class, but those that you might talk about with other faculty members or those that might be particularly helpful for studying for the board exam. So I'm going to go through one example with a clinical sign of rash. And what I'm going to do is start with that one particular defining feature, then break it into subcategories, and then break it further into the possible infectious agents, and then give a quick word for how would you differentiate each one from one another, and then ultimately how would you treat each one of those. Those are the kind of things that you're going to want to be able to do for yourself based only on a clinical story. Okay, so let's start by writing the word rash. That's terrible. Rash up at the top, okay? That's our master clinical sign we're dealing with at the moment. And then let's break that into some subcategories. First over here, we're going to put vesicular rashes. So those are the ones that more or less erupt and are kind of fluid-filled. And then over here, we're going to put hive-type rashes. These are the ones that are flat and red and very itchy. They're basically have an allergy-type pathology to them. But again, of course, can be infectious in nature. Over here, we're going to then put petechial rashes. In my particular class, we've only talked about one of these and mentioned this very briefly, but petechial rashes aren't really true rashes. What they actually are small spots of hemorrhage under the skin, and they're not actually raised like that at all. They feel very flat, but they don't blanch, meaning if you press on them, they stay just as red. They don't turn white at all under pressure. And what those are due to is subdermal capillary leakage. And then the last one over here, we're going to have maculopapular. So these are the guys that are, again, smooth and red, but they do blanch. Meaning if you press on them, they'll kind of turn white until the effect of the pressure goes more or less away. Okay, so if you look back at your notes and class slides, you've seen a lot of pictures of each one of these, with the possible exception of petechial rashes. So if you need a good visual on those. But what we want to do here is, again, use this as an example for how to study well. All right, so if we want to start over here with vesicular rashes, what I would do is start thinking about who are my most probable causes for vesicular rashes. Who are some of the main culprits? And to me, the first one we would talk about are herpes rashes. Another one, and that we might call that herpes simplex, either cold sores or genital herpes presentations. Over here, we're going to put VZV, which, yes, is, of course, a herpes virus, but I'm just, for some reason, putting it in a different category tonight. This would be your chickenpox rash and your shingles. And then the next one that we talked about was smallpox. And then a final one to bring up is hand, foot, and mouth disease virus. And this, again, is either Coxsackie or enteroviruses. Okay, so then once you've gotten to this point, I'm going to kind of separate this out, and I'm going to take a moment and just go through the vesicular ones to the end, and then we'll kind of go through these other guys quickly. what you want to do now that you've kind of broken it into some groups is to say, all right, if I suspect a patient has herpes simplex virus, how would I officially determine that? And you would, if you're talking about HSV2, you'd ask about their sexual history. You would look at the physical appearance of the lesions and the anatomical site of them. You would then do some rapid molecular testing through your diagnostic lab. And then if you had definitively diagnosed herpes simplex, how would you treat it? And hopefully you're thinking to yourself, I would use some derivative of acyclovir, either orally if you're talking about genital herpes or topically if you're talking about oral herpes. All right. And now what we would do is say, all right, let's move to VZV presentations. If you have a patient with a vesicular rash, but herpes simplex doesn't seem to be the correct call, we'll move over here. Is it VZV? For chickenpox, what you're going to want to look at is vaccine history, clinical presentation. Remember, we talked about chickenpox rashes start on the trunk and move outward, as opposed to many of the other childhood rashes that you see. Saying of which, age is also critical here. If you decide you've got probable chickenpox, how are you going to diagnose it? You would do serology. You would look for anti-VZV antibodies. And how would you treat it? And of course, the answer here is that in many cases you don't treat chickenpox, you do supportive therapy. You help patients to feel better, you control their fever. If they start to develop any complications like VZV-related encephalitis, something like that, then you would take them in and start treating them with anti-herpes medications. For shingles, what you would want to do if you suspected that, remembering that shingles is going to, again, being caused by the same virus, but you're talking typically about a different age population. And here you're looking at usually elderly patients or immunocompromised patients. You would want to look for vesicular rashes, but only apparently occurring along one site in the body. And that is going to correspond to one patch of neuronal chains. And what you're going to see there are fluid-filled vesicles in one place, and they're extraordinarily painful. And again, another thing that's important here is that your patient would have to have a history of chickenpox. If you haven't been infected with VZV, you can't, prior in life, you aren't going to primarily present with shingles. And then if you decide you have a vesicular rash, you decide it's not herpes, it's not VZV, you might want to come over here and think about hand, foot, and mouth disease. So remembering here, all right, the trick with hand, foot, and mouth is that we've got these oral lesions, and those then progress to these vesicular rashes on the hands and the feet, hence the name. They can go up the arms and down the legs, but the general point here is that these vesicular rashes start in the mouth and then they go to the extremities. There's no initial involvement of the trunk or the face. That's quite different. This is also something that you typically see in smaller kids. Once you get to that point of suspecting hand, foot, and mouth, you go back to your thought of, how do I diagnose it? This is usually empirically diagnosed, although I suppose you could do it by serology if you really wanted to. And then you go back to, how would I treat this? And of course, the answer here is also supportive. If you went, if none of those fit and you had a really terrible day, you might want to consider smallpox. The real deal here, it's, again, clinically, the way that you see this presenting is with a vesicular rash that's going to start on the extremities and move inward as opposed to the trunk and outward. So we'll go extremities in on our chart here. But the real situation with smallpox is you really want to think long and hard about index of suspicion. It's extraordinarily low for smallpox. If one had to differentiate this from chickenpox, would be the the clinical severity of the situation. Chickenpox patients are quite sick, but they're not smallpox sick. This has about a 30 to 40% mortality rate, and so these folks are quite sick. I'll put high M rate here. Okay. Mind you, there are plenty of other vesicular rashes that are far less common or less noteworthy, but this is just to give you an idea of, now having gone through several weeks of micro, how I would go about organizing something like what causes rashes. I would start with the different types and move on from there. These all happened to be viral, but now we're going to move into some of these issues where things start getting a little more mixed up. Before we do that, we're going to take a really easy jaunt over here and talk about hives. There's the most predominant infectious agent that's going to cause a presentation of hives is the disease known colloquially as swimmer's itch. So this is an IgE and eosinophil mediated pathology, and so it presents very much like an allergy. We talked about this being associated with a parasite called Trichobilharzia, and this is a guy that you tend to find in freshwater lakes and ponds and things like that. It's a parasite of waterfowl. And when that parasite's antigens come in contact with skin for individuals who've been sensitized, they have what is essentially an allergic response to this. And that's really the most common infectious agents that's really going to give you a rash that is essentially the same as hives. Okay, so that being said, here's where things start getting a little more tricky. Now, I reiterate, we have not talked about any but one infectious agent that causes petechial rashes. However, there are plenty of them, and there are some that are, the others I'm going to bring up here as your kind of method for studying, because they're quite common, are bacterial. And it's a great example of the fact that different clinical presentations can be just as plausibly caused by different types and categories of infectious agents. So even though we teach virology and we teach parasitology and we teach bacteriology, there are things within those categories that can certainly give you a common clinical presentation. So the petechial rash causing agent that we talked about in virology was dengue fever virus, and in particular, this presentation is dengue hemorrhagic fever. The way that you pull this apart is that you have to have had previous dengue infection, and that you typically have a whole lot of pain, fever, etc. You would diagnose this by serology, and you would, if you were thinking about treatment, you would go with the supportive therapy method. The other two important causes of petechial rashes to cover that are infectious would be Rocky Mountain spotted fever, which is a bacterial disease caused by Rickettsia species. And this is, again, going to give you an all-over pinpoint hemorrhagic rash. And this is tick-borne illness, although this is often spread by nymph ticks, so they're very small, and the patient often doesn't realize they've been bitten. And this guy you diagnose by serology. You want to note here that this has a seasonality to it. And once you have a definitive diagnosis, you would treat this with antibiotics. And again, I know you haven't had this in class yet, but you would be dealing with something, you would typically be dealing with doxycycline to treat this. You will learn that later, I promise. Or for anybody on the internet machine who happens to be listening to that, I don't know if you've learned it yet or not, but have a ball studying it. The last one that I think is really important to bring up is meningococcal meningitis. That's caused by Neisseria meningitidis. Your index of suspicion here is vaccine history, and the fact that you tend to see this in constellation with meningitis symptoms, a patient who comes in with very high sudden fever, very, very painful stiff neck. They might be quite disoriented, have had a lot of vomiting over the past few hours, and then this rash will start appearing on the arms and legs. So this is an extremity rash. But if you start seeing this patient is starting to go in a very bad direction, and you would diagnose this empirically because it's critical that this patient starts being treated very, very quickly. And the ultimate diagnosis would come from something like a CSF gram stain, followed by definitive identification of Neisseria meningitidis in the cerebral spinal fluid. Treatment for this is high-dose IV antibiotics. Okay. And now we've talked about vesicular rashes, hives, petechial rashes, and now we're going to go with maculopapular rashes. Good times. So this is a type of rash that a wide variety of infectious agents can present with. And so the way that I'm going to bring this guy up is to say who's on the extremities, who starts on the trunk, and who starts at the hairline. So the guys who start on the extremities would be, the extremities being the hands, the feet, the palms, the arms, legs, things like that. We have secondary syphilis. We have West Nile virus. We have Zika virus. And we have any number of general, rarely discussed, often vector-borne viruses will present with kind of this non-specific extremity rash. Many of them have never been cultured, many of them have never been described. And the reason for that is that they often resolve on their own. But that being said, if you suspected syphilis, West Nile, or Zika, you would be asking about indices of suspicion for all three of those, which are quite different. For syphilis, you'd be asking about sexual history. For West Nile, you'd be looking at it from a seasonality and geography standpoint. For Zika, you'd be looking at it from a geography standpoint. And in addition to that, once you've figured this out, for syphilis, your clinical lab has a two-pronged approach to diagnosing it, and both of those are molecular. For West Nile and Zika, both of those are molecular in nature. So they're going to be detecting flaviviral RNA in either case. Once you've diagnosed any of these, you would want to think to yourself, if I have a syphilis patient, what do I do? You treat them with antibiotics, most often beta-lactams, although there's emerging resistance to that. If you're dealing with West Nile or Zika, you treat them supportively unless they have particularly relevant complications. For West Nile, if they develop into West Nile encephalitis, obviously you're talking about an inpatient treatment situation. If you're dealing with Zika virus, if you're talking about a pregnant woman, you've got a long-term monitoring situation on your hands. Okay, so those are our extremity maculopapular rashes. For our trunk rashes, we want to be thinking about roseola infantum. Hence the name. You typically see this in children under the age of 2. And this is a sort of a very common childhood illness. You see this starting on the trunk, spreading outward. You might have a low-grade fever with it. You might have fussy babies with it, but they recover quite nicely. You would also want to think to yourself, all right, maculopapular, trunk rash, what else could that apply to? And the other answer is fifth disease. So this was also fits into another category of rashes that I haven't written yet, but I will I'll put it right here, right now, erythemas. But the trunk rash aspect of Fist's disease appears after the erythematous presentation, which is that kind of slapped face presentation. You see appearing on the belly about 2 or 3 days after the red cheeks, this nice lacy macular papular rash. Looks very lovely, like these conjoined circles. The index of suspicion here would be that you're typically dealing with children that are usually under the age of 5, though they can be as high as 7, 8, 9, that type of age range. They tend to have a fever, they tend to just not feel good, but other than that, that's pretty much the only remarkable thing about it. These are usually diagnosed empirically, and their treatment is supportive. The last guy that we have over here are the hairline rashes, and the biggies that we want to point out here are measles and rubella. Both of these guys, again, are going to start at the hairline and move down the face and then move inward toward the trunk. Both of these guys have measles in particular, though, has a nice prodromal stage of sort of an influenza-like illness. You have these sniffles and you have a patient that just doesn't feel very well. With measles, the way you can pick it apart from rubella very nicely, other than geography and index of suspicion, is that measles patients get those Koplik spots. My stylus isn't writing. Koplik spots on the inside of the cheeks, so just red dots inside the cheeks. Rubella has been eradicated from the Western Hemisphere, from North America, I apologize. However, that could always change in the future. So at the moment now, if you're practicing medicine in the Western Hemisphere, if you see a hairline down rash, that is maculopapular starting at the top of the hairline, going towards the face where you have an associated fever, and you happen to have noticed Koplik spots, then you would think this, not this. And rubella, once again, does not have Koplik spots. In either case, you're going to diagnose these by serology again, looking for antibodies, and your treatment is, once again, going to be supportive. But you want to put a star for yourself here that these are, of course, reportable illnesses, as is this guy, for obvious reasons. And while I'm at it, as is this guy and this guy. Okay, so those are our vesicular, hives, petechial, maculopapular, and as the last thing we would point out for rashes would be your erythematous rashes. So basically, or just in general, erythemas. So that's big red patches of skin. And so for me, what I would break this into is, do we have concentric circles? So that's kind of something that would look like this, and then a bunch of circles going around it. Or do we just have just redness? And if you were dealing with concentric circles, the two biggies that I would think of would be ringworm or Lyme disease. And how you would want to think to yourself, how do I tell those two things apart? So this would be a fungal infection. This would be with Tinea species, and this would be a bacterial infection with Borrelia species. And so obviously you're going to treat those very differently, so you would want to be sure that you're interpreting your rash with a concentric circle correctly. So the way you tell these two apart from each other is that ringworm patients aren't sick. They just have this funny lesion, usually on their limbs, and it itches. But these guys have no fever. They have no symptoms generally, except for the skin irritation. Lyme patients are sick. These guys tend to have fever. They tend to have aches, pains. They tend to be anorexic. They tend to have severe malaise. So the way that you diagnose each of these guys is to look at ringworm, that's empirical, and to look at Lyme, that's laboratory based, and often that's still serologically based. How do we treat ringworm versus how do we treat Lyme? You're going to treat Lyme with prescription antibiotics, most typically doxycycline. With ringworm, you're going to treat that with over-the-counter antifungals, so something like miconazole. So we have our concentric circles. If you have just plain redness, that could be a whole bunch of things. And again, we're talking about redness of an infectious origin as opposed to redness for any other reason. But the biggies to me would be intertrigo, and that's usually a fungal infection with candida, and the other would be a cellulitis, and that's typically associated with staph or streps. The difference here is that intertrigo, you typically see it in anatomical sites where you have a lot of folding and damp moisture. So you could see it on the inside of the thighs, you can see it in the folds underneath women's breasts, you can see it in underarms, and it's more of a nuisance. These patients aren't sick. They just have a very painful skin irritation. Cellulitis patients, on the other hand, are sick. They tend to have fevers. They tend to have severe pain. They often are in a position of not being able to effectively use the body part that has the cellulitis infection. The way that you diagnose intertrigo would be, again, empirically. The way you diagnose cellulitis would be empirically, so you can start treatment and then you'd follow it up with culture so that you can typically look at antibiotic susceptibility. And then what you would do in terms of treatment for intertrigo would be usually you'd start with a topical antifungal, again, like a Lotrimin or something like that. If that doesn't work or it irritates the skin further, you can go to a fluconazole, like an oral antifungal medication. And for cellulitis, obviously, you're talking about something much more serious, depending on the extent and the spread of the cellulitis and how aggressive it appears to be. You might want to go with either an oral or an inpatient IV situation for antibiotic usage, and then which antibiotic you use is going to be dependent on the culture and sensitivity results from the clinical lab. So all that being said, we've spent half an hour talking about rashes. You would want to do this with all clinical presentations. Okay, so you want to think about this. You could start with neuro and then say, okay, I'm going to break that into encephalitis, meningitis, neuropathies, meningoencephalitis. And then you might go down into, all right, what are my causative agents of meningitis? So we had talked about, there are some viral meningitis. You have some enteroviruses. There are certainly plenty of bacterial causes. Most notably in my mind, you would be looking at Neisseria meningitidis, Haemophilus influenza, strep pneumo, and if you're looking at infants, you'd be looking at group B streps and Listeria monocytogenes. And then you would want to say, all right, how do I diagnose each of those? How do I treat each of those? Then you would move over to the encephalitis category. Okay, what causes encephalitis? Okay, we had talked about West Nile virus. You could talk about Powassan virus. You could talk about cerebral malaria. You could talk about rabies is technically an encephalitis. So you would want to go through all those infectious agents that cause that. Then you'd move over to neuropathies and start thinking about varicella zoster and shingles presentation. And then you would look over at meningoencephalitis and say, okay, so there were plenty of things that we talked about that would cause that. There are mycoplasma causes, there are amoebic causes, et cetera, et cetera. So by individual week, we broke this into clinical presentation and talked about all the viruses and then all the parasites. But when you're trying to put all this information together, the best way to do it, I think, is to go back to clinical presentation, and then start integrating all these different types of pathogens and thinking about them from the way of how do I pick that out of a patient? What's the red flag for that? And then how am I going to diagnose it? And if I diagnose it, how am I going to treat it? And what other practical things do I need to do? Is this a reportable illness? Is this something that I have to quarantine their household members over? Is there something that I have to worry about who lives in their household in terms of pregnant women or in terms of elderly relatives? Things like that. So that being said, that's a lot of work, but if you put it all together that way, I think that would be really the most effective way of studying and integrating this material. That said, have a lovely night, and I will see you all soon, unless you are random people watching on the internet, in which case, flame on, God bless, and everything else. Adios.